Hey, friends, we're going to talk about what happens when the fetal heart rate deviates from the baseline. So these are your episodic and periodic changes. I am not testing on the terms episodic and periodic changes, but I just want you to kind of understand them conceptually. So episodic changes occur at random. So you could say the fetus is having an episode of some kind. These include accelerations when the heart rate goes up from the baseline. They are reassuring, they're good episodic changes. Variable decelerations, they usually a result of cord compression, and they can occur at random as well because of positioning or because of a contraction or because the baby moved or grabbed its cord. But it's an episode. Prolonged decelerations are decelerations that indicate a sudden event. They last longer than 2 minutes, but less than 10. So they're between 2 and 10 minutes long. If it's 10 minutes of a lower heart rate, what we have is a change in baseline, and now we're going to call it bradycardia instead of a prolonged decel. And we don't like to see a prolonged decel last. Periodic changes are changes that occur in relation to contractions. So they follow a more or less predictable pattern. In that category, we have early decelerations, which are caused by head compression. Every time that contraction happens, you're going to see a dip in the heart rate that mirrors it. Late decelerations occur, they start in the middle, and then they slowly go down to their bottom point and come up sometime after the contractions. But they do happen in relation to contractions, and contractions happen in a pattern usually. Okay, so let's go into each one of those things a little bit more detail. Accelerations, 15 beats per minute above the baseline times 15 seconds if you're 32 weeks and above. If you're under 32, they can be 10 by 10. That's fine. But here you see a baby with a baseline, follow my little pointer, of 150. And the heart rate then goes up to about 170. Does it, 165 there. But these are accelerations. They are at least 15 beats above the baseline. And they last, this one lasted about 20 seconds. This one lasted about 25 seconds. So we know that that baby has good oxygenation and their central nervous system is intact. They are responding to a demand for movement or some other need for more oxygen. So more about accels. Accelerations of the fetal heart rate are very reassuring. We love them. They indicate the baby can respond to stimulation or increased demand. Sometimes if we're concerned about the tracing, somebody will do a vaginal exam and tickle the baby's head a little bit and see if that baby has an accel in response to that. That's called scalp stim. It's an assessment. You try not to do it when they're in a decel, but if they've got minimal variability and you're worried about them, you can tickle the head and see if they respond to it. Things a baby might say during an acceleration. I feel great, so much energy. I love my mom. That's what a baby's saying during an acceleration. Variable decelerations. It's a shame that this word sounds so much like baseline variability. It is a separate concept. So a variable deceleration has an abrupt descent. Abrupt meaning less than 30 seconds from the baseline to the bottom. We call the bottom of a deceleration a nadir. I won't get that tricky with it, but they're usually V-shaped because of that abrupt descent, or sometimes even a little more U-shaped. I've even seen a couple that were like W-shaped because it was like two events on top of each other. This is a response to cord compression. Now, these variables happen to occur with the contraction, which tells me it's happening because when the uterus contracts, it compresses the cord. This would be a case to turn the patient over. If it continues, we might consider amnio infusion, which actually instills fluid into the uterine cavity to cushion the cord. A little more about variables. Occasional variable decelerations are common, especially in labor. Cord gets stretched, it can get compressed with an occasional contraction. Usually repositioning that patient will work. Books say left, but sometimes that cord's on the left. Keep turning that patient until you get what you want. If they're not good on their left side, turn them over to the right side. If they're not good on that, put them in high Fowlers. Keep repositioning that patient. The one thing you don't want to do is lay them flat, but a semi-Fowlers or a high Fowlers, you're trying to find a place where that cord's not going to get compressed. Recurrent variables stress babies, they stress nurses, they stress providers, midwives, doctors, all of us. And sometimes we will go to that amnio infusion using that IUPC to instill fluid into the uterine cavity. Things a baby might say during a variable deceleration. Oops, found my cord. Hey, mom, can you roll over? You're laying on my lungs. Or, hey, would somebody move this jump rope thing out of the way? I'm not feeling so good. Those are things a baby might say during variable deceleration. And we have prolonged. Prolonged decelerations last longer than 2 minutes, but not longer than 10 minutes. And here they are. And boy, isn't that ugly. Just ugly. So if a baby has one of these, sometimes it's because they've descended too rapidly, or, there was a response to a blood pressure, or mom was laying on her back, and we can fix it. But you need to monitor this. This is not a baby you want to say, I'm going to the cafeteria for 10 minutes. If you're running Pitocin, you're going to shut that off. Something happened in here that made that baby fall down the stairs. Sometimes it's rapid decentering labor. Like I said, the patient goes from 0 station, which is the presenting part level with the ischial spines, and they've gone all the way to +3 in one big contraction. And they're sort of adjusting to that. And sometimes we see it when moms get epidurals and their blood pressure drops. If that's the case, fix mom's blood pressure. We'll talk about that when we talk about medical interventions for labor. But other times they're caused by a baby who just doesn't have the reserve to tolerate labor. And we would, in all cases, initiate what's called intrauterine resuscitation. Stay tuned for that later. If you can't get it to improve, you've done everything you can do. The provider's done everything they can do. It's time to deliver this baby, generally. If they're very preterm, that is a whole different decision-making process. But usually they can't tolerate multiple events like this. So things a baby might say during a prolonged deceleration. I suddenly feel really awful. Help me. Who sucked out all the air in this room? I'm falling and I can't get up. Earlies. We are on earlies now. Earlies aren't bad. Earlies mirror the contraction. So see, here's the contraction starting right about here. If we drew a straight line up, we would see that's when fetal heart rate starts to descend from the baseline. Now we go to the lowest point, the nadir, and we go straight down that line. And look, we're at the peak of the contraction. Now let's go to the end of the decel. And if we line it up, our contraction is over. Okay, it mirrors the contraction, just like that. And it does it again. Okay, and here we are again. Start at the beginning of the decel, line it up, same line as the start of the contraction. If we go to this line, we see that we are right at the peak of the contraction. It's a mirror image. If you folded this paper in half, you'd get something kind of similar. So they are caused by head compression. I'm going to give you a mnemonic for this. Just listen. And then I'll give you the little cheat. As a contraction moves the baby down, the compression on the baby's head stimulates the vagal nerve, and that lowers the heart rate. Usually this is fine. It's generally a sign that baby is moving down. And as long as you've got moderate variability, you're not seeing anything worse on that strip, this is a sign that you should be starting to get ready to have a baby. The only time these are a real big problem is when it's still early in labor and your baby is +3, which means they're still floating in the pelvis. And that might mean that the baby's head's already getting squeezed. It's not even engaged in the pelvis. They might be too big. Things a baby might say when having earlies. What's squeezing my head? Ooh, is it finally my birthday? Great. This pressure is no joke. This hat's too tight. And now we have lates. Start after the contraction begins, usually about the midway point. This is a baby who's like, I'm trying to maintain a baseline, and then the stress of the uterine contraction. And uterine contractions do restrict blood flow somewhat to the baby. When that baby is stressed by that contraction, it gradually starts to go down, hitting its nadir, lowest point, somewhere after the peak of the contraction. It's stressed out. It used up all its energy trying to deal with that contraction. It takes a long time to return to the baseline. Sometimes these are subtle. It doesn't matter. They're still bad. So there are things that we do to help increase blood flow to the through the placenta. But you'll see there's a pattern. And I want you to note that this baby also has minimal variability. I can detect some amplitude of really not a whole heck of a lot. This is a cause for concern. There is not enough blood and oxygen getting to this kid, and it probably is being caused by labor. So, lates are a sign of uteroplacental insufficiency. If they're recurrent or if they're accompanied by minimal variability, they require intervention. We start our intrauterine resuscitation. I promise I will get to that. And the Pitocin, if you're using it, should be turned off if they are recurrent. If you have one isolated late with moderate variability, you're still watching. You're still going to monitor and surveil, but you can usually get the baby to recover. They're usually not too compromised at that point. Maybe that one contraction kind of squeezed off their blood flow a little too much. Maybe it was a little too, maybe there wasn't enough time for the placenta to refill in the intervillous space. But, we're really looking for a pattern here of a baby who's not tolerating contractions. So when a baby might say during a late decel is, I'm trying to be okay, mom, but I just can't do it. Labor's stressing me out. I'm suffocating. Help me. Oh no, not another contraction. Help me. Okay. So now here's the mnemonic as I promised. Can I make this screen any bigger? No, I can't. So V for variables goes with, in veal, goes with the C in chop for cord compression. So the E in the word veal goes to the H in the word chop. Early decelerations mean head compression. Accels, the A in the veal chop, go to O for oxygen. You could say okay if that makes you better, but that's how you remember. Your baby's okay, they have oxygen. The L in veal goes to the P in chop. Lates mean placental insufficiency. That is your mnemonic. Okay, we are going to stop here, take a break, come back.